We are live.
Good evening, friends. It's been a pride and pleasure for me to be the convener for this important academic initiative of the IAGES. I'm happy to welcome our president, Professor Sunil Papat, an eminent endotherapist and minimally invasive surgeon with a special interest in foregut surgery. He has taken over IAGES at the most challenging time and has been guiding us with more effective relief measures and balancing the academics as well. He's also the chairman of the Nidhi Hospitals Ahmedabad, and to his first, he has hosted the national conference, regional conferences, advanced laparoscopic courses, basic courses, and he has served from the member to the president in all positions of the IAGS. With that few words, I warmly invite our national president, Professor Sunil Papat, to give his presidential talk. Over to you, sir.
Thank you, Dr. Kanagwal. Good evening, friends, IAGS members, and my dear faculties. It is a great pleasure and privilege to welcome you all to yet another exciting session of IAGS Prime Time. IAGS started this virtual academy last year during COVID pandemic, and every fortnight we are coming to you with excellent faculties, excellent topics on Wednesday evening. Tonight, we are touching upon two very important topics. One is the role of subtotal cholecystectomy in the situation of acute severe cholecystitis, and the another one is the management of Achalasia Cardia. Now, all of us are practicing laparoscopic surgery, and some of us are also practicing GI endoscopy since many years. Subtotal cholecystectomy has been there for few years as an important procedure. However, there are pros and cons. So today we have devised this program as a debate, and we have eminent faculties from all across the country to give talks as well as to moderate the sessions. Friends, during this pandemic time, IAGS has been at the forefront of doing the philanthropic activities, and IAGS developed and had a IAGS COVID task force, which did wonder, which collected a lot of funds, bought COVID relief materials, and distributed all across the country in all the corners of India. Friends, tomorrow is a Doctor's Day, and this is a salute from IAGS to all our IAGS members and to all our doctor colleagues. With these few words, I invite Dr. Kanagwal to start the proceedings for tonight, and let's have a wonderful night of academics. Thank you.
Thank you, Mr. President, for staying and guiding us with a brilliant leadership. Now we move on to the academic session. I'm very happy. In fact, Dr. Ramesh Agarwala has been my mentor and who has been instrumental in me coming into IAGS mainstream. Dr. Ramesh Agarwala has been past president and currently now the trustee of the IAGS. And to add to the feathers of the IAGS, he is right now 6 research projects under him, and many are on the pipeline. And I'm sure none of the national bodies or international bodies are proud to have a research unit, and IAGS is a very strong research unit, and he spearheads all the activities. Dr. Ramesh Agarwala is the chairman and head of the minimal invasive surgery at the Fortis, Kolkata, and has been always dynamic leader, and he has been always allowed inclusive partnership, and he's always seen the young ones are taken care well and they are in the ladder of the leadership. With that few words, I now welcome Dr. Ramesh Agarwala sir to take over the coming 45 minutes, conduct this very important session on subtotal cholecystectomy. On behalf of the IAGS, President of the IAGS and the Executive Committee, I take pride in welcoming Dr. Ramesh Agarwala for moderating this session. Over to you, sir.
Thank you very much, Kanavel, for your gracious introduction. I don't think I deserve all. I welcome all of you to this another edition of IAGES Prime Time. This has become a very, very popular program, and the topics chosen address the questions and controversies in the mind of the young and not so young surgeons. I would like to compliment our current president, Dr. Sunil Popat, Dr. Kanavel, and the entire academic team for conceptualizing this program. Today's program is a debate on usefulness of subtotal cholecystectomy in severe cholecystitis, calculous cholecystitis. We have two eminent speakers, two very well-known surgeons who are known in India and abroad and who need no introduction. Dr. Deepraj Bhandarkar would be speaking for the motion, and Dr. Lakshmi Konakumari would be speaking against the motion. As we know, gallstone disease is a very common in our country, and laparoscopic cholecystectomy is the gold standard for gallstone disease. We all have to deal with severe cases of severe calculous cholecystitis, where we adopt different measures to successfully complete the procedure without any complications, especially bile duct injury. Subtotal cholecystectomy is one such method which is employed. Over the next 30 minutes, we will find out the usefulness of this procedure. I welcome our president, Dr. Sunil Popat, Dr. Kanavel, Dr. Deepraj Bhandarkar, Dr. Konakumari, and all the delegates to this exciting session. As I said, both the speakers need no introduction, and they have so much to their credit that it will take me another CME to talk about them individually. But still, I would like to say a few words about Dr. Deepraj Bhandarkar, who is a consultant general and minimal access surgery attached to Hinduja Hospital and Breach Candy Hospital with more than 30 years of experience. He's done his FRCS, MS, FRCS, and diploma in laparoscopic surgery from Germany. And he has many things to his credit. He's got the traveling fellowship of Royal College of Physicians and Surgeons of Glasgow to visit the Royal Brisbane Hospital, Australia. He's been the editor, I would say right from beginning, the editor of our JMAS, and he's brought JMAS to this height. He's done many positions in IAGES. He's worked as a vice president, the treasurer, the EC, and he's also been very active in the Hernia Society of India. He's been the secretary, now he's the president-elect. And there are so many other things. He's also been the course director for laparoscopic general surgery at the Center of Excellence of Minimal Access Surgery Training, that is CMAS. And there are many more things. I can keep on and on. But welcome, Deepraj. We are all looking forward to hear your views. Dr. Konakumari is also a very senior surgeon with more than 25 to 30 years of experience. She's attached to Apollo Gleneagles Hospital in Hyderabad. And she's head of the department, and she is very active. She has also donned many caps in IAGES and other associations. She's worked as the executive member, as the vice president, and she's also conducted many conferences and has many papers to her credit. She has performed more than 25,000 minimal access procedures with more than 1,000 bariatric procedures, and has highest number of single incision scarless bariatric surgeries in AP and Telangana. She's worked in NUH Singapore and worked at Cleveland Clinic, Ohio, USA. So with these few words, I welcome both the eminent surgeons, and over to you, Deepraj, for your views on subtotal cholecystectomy.
Thank you very much, Ramesh, for those kind words. And special thanks to Dr. Sunil Popat for this kind invitation, and also to Dr. Kanavel. I'm sharing my screen now. Just tell me if it's seen properly. Can you see the screen?
Yes, it is, Dr. Deepak.
Okay, thank you. So the task that has been assigned to me is to debate for the usefulness of subtotal cholecystectomy in the setting of severe acute cholecystitis. I have no disclosures as far as this particular talk is concerned. And what I hope to do in the next 12 to 15 minutes is touch upon this agenda. We will first look at acute cholecystitis as a risk factor for bile duct injury, which is the most dreaded complication of laparoscopic cholecystectomy. We will put forth a conceptual roadmap of 3 steps to avoiding bile duct injuries. What are the 3 most important tenets in avoiding bile duct injuries during cholecystectomy, particularly when undertaken for acute cholecystitis? We will briefly look at the history and the types of subtotal cholecystectomy, and then we will go on to look at the evidence and the guidelines which today very strongly favor the use of subtotal cholecystectomy in appropriate settings. So we all know that acute cholecystitis does increase the risk of of bile duct injury. By how much? It has never really been calculated or predicted, but this was a paper from the World Journal of Surgery in 2015, which was a population-based case control studies. And as you can see from the chart, from the table, you can see that when you have a moderate, Tokyo type 2 acute cholecystitis, the risk of bile duct injury, the odds ratio of a bile duct injury is 2.41. That means there is a 2.4 times higher risk of a bile duct injury. The worrying thing is when you have a severe acute cholecystitis, a Tokyo type 3, that risk exponentially goes up to 8-fold. Now, a 8-fold increase in bile duct injury during a laparoscopic cholecystectomy cannot simply be accepted. And we have to figure out a way for mitigating this risk. In other words, a surgeon has to, at all costs, protect the bile ducts from getting injured. This was an excellent paper published recently by Professor Steven Strasberg, who has written quite a lot on the subject of safe cholecystectomy and bile duct injury. And in this paper, which was in fact an invited review, he puts forth a 3-step conceptual roadmap for avoiding bile duct injury during cholecystectomy. So the first step, which is something that we all as surgeons performing this operation familiar with, which is establishing the critical view of safety, the components of which I'm going to not reiterate here, but it involves secure anatomic identification before any structure is clipped or divided. The second step is what he calls the inflection point during the surgery or the turning point of the surgery. For any reasons, if the surgeon feels that he is approaching a point of danger, he should know when to stop and then take appropriate steps in order to avoid injuring the bile duct. And the third step is the maneuvers which are performed after he has clearly identified that the inflection point has been reached. Professor Srikhande, who is one of the pioneers of biliary surgery in this country, once very famously during his talk said that like a safe mountaineer, a safe surgeon never crosses the point of no return. And that's the whole idea of identifying that point. If you cross that, if you continue a dissection, you're likely to cause bile duct injury, and stop at that point and take certain actions. So what could those options be? Those are described as bailout procedures. And bailout procedures are the procedures which allow the surgeon to complete the operation safely. And again, here there are 3 scenarios. One is that after a preliminary laparoscopic examination of the liver and the hepatocystic area, you cannot simply find the gallbladder, which is extremely rare. But this happens when the gallbladder is so shrunken that it is practically impossible to find it. At this point in time, the surgeon has to make a calculated decision as to whether it is safe for him to convert the operation, and does he have facilities like, say, an intraoperative ultrasound to try and figure out that small shrunken gallbladder, and the expertise, particularly in open biliary surgery, to perform a cholecystectomy for that gallbladder, which often may be the size of a peanut? Or is it simply better to retreat, document what has been found during the surgery, and refer the patient to a more experienced biliary surgeon? The second option is only fundus can be exposed, and below the fundus there is either a fistula, or there are such severe adhesions and such severe inflammation that proceeding downwards or medially towards the bile duct is fraught with danger. And this is a scenario in which cholecystostomy, after opening the gallbladder, clearing out all the stones, irrigating the gallbladder cavity, a cholecystostomy can be performed and the day can be saved. The third option is when the surgeon is able to reach the hepatocystic triangle, but fails to achieve a critical view of safety even after a preliminary trial dissection. And this is the situation which calls for two things. One is either pursuing the operation laparoscopically and performing a subtotal cholecystectomy, or converting and performing a subtotal cholecystectomy. When we think in terms of subtotal cholecystectomy, there is often a confusion in the name. Should it be correctly called a partial cholecystectomy, or a subtotal cholecystectomy is a more appropriate name? The term partial usually indicates that you are removing only part of an organ, whereas subtotal has the connotation that you are making an effort to remove as much of an organ as possible. And that's why in the context of cholecystectomy, which is a near total or a subtotal cholecystectomy, the latter name is or seems more appropriate. It is interesting that after the first open cholecystectomy was performed in 1882 by Langenberg, there were reports, some early reports of surgeons having to resort to a method which did not involve a complete cholecystectomy. In fact, way back in 1893 or 1894, the surgeon who described the T-tube, Kerr, actually has documented the use of a subtotal cholecystectomy. But the first paper which was published on the subject is this one in the American Journal of Surgery in 1938, where the surgeon, he is depicted as beautifully, he has opened the gallbladder, emptied out the stones, and simply kept the gallbladder mouth open with some Penrose drains in that to drain out the area. It is interesting that in the discussion, he mentions that the surgeon Estes, had an occasion to reoperate on 4 of these patients. So this is a series of about 16 or 17 patients. And he had the occasion to reoperate on 4 of those patients. And he makes a mention that no vestigial or anything resembling a gallbladder could be found in the gallbladder fossa. So in other words, having re-explored the patient, there was no gallbladder stump or a remnant gallbladder in these patients after performing this operation. The laparoscopic subtotal cholecystectomy gets described in the literature for the first time in 1993, within 7 or 8 years of Eric Muhe performing the first laparoscopic cholecystectomy in 1985. So this was a series of 6 patients, and the authors mention that this was carried out, a subtotal cholecystectomy was performed in order to reduce the operative time and avoid the excessive bleeding which may have ensued and necessitated a conversion. So the term subtotal cholecystectomy has been around in the literature for a long time. It was this paper, again from Professor Strasberg in the Journal of American College of Surgeons in 2015, which specifies 2 types of cholecystectomy. The first one is called a fenestrating type, in which it is impossible to oversow the gallbladder remnant or a stump, and in which a purse string is taken around the mouth that can be seen within inflamed tissue, the presumed cystic duct leading onto the bile duct, and a drain is kept. And the other one is called the reconstituting type, where you can actually fold a part of the gallbladder, posterior gallbladder wall, and close that stump, or take a running stitch on a cystic duct. This slide documents the advantages and disadvantages of these two types of subtotal cholecystectomy. With the fenestrating type, biliary fistulas are more common as expected because you're not really making any efforts to close the opening. Most resolve spontaneously, but some may require endoscopic intervention. With the reconstituting type, as expected, bile fistulas are infrequent, but sometimes result in a gallbladder remnant, and a small percentage of these patients go on to require a second operation. And this paper in 2016 indicated that fenestrating type is the preferred method. We will see in some of the recent literature that it has been shown that reconstituting type seems to be the better subtotal cholecystectomy to perform. So this was a comparison of the fenestrating and the reconstituting type of subtotal cholecystectomy, a paper which appeared in Surgical Endoscopy in 2020. 39 studies, 1784 patients, and they documented that the fenestrating type of cholecystectomy, where you essentially leave the mouth of the cystic duct open just with a drain, was associated with higher incidence of retained stones, higher incidence of subhepatic and subdiaphragmatic abscesses, higher incidence of surgical site infections. Need for postoperative ERCP was much higher, and the reoperation rate was higher. A paper which appeared just a couple of months ago in Surgery was a systematic review of almost 85 studies published between 1985 and 2020. Several thousand patients, close to 3,600 patients. And in this series, the authors state that 0.2% or 7 patients sustained a bile duct injury, and about 14% of the patients had a bile leak in the postoperative period, which required intervention in one form or the other. And again, these authors state that the reconstituting type of subtotal cholecystectomy is better. Whenever you can safely close the stump with a running suture, it is a better option than leaving it open simply with a drain. And they also go on to point out that if you opened the patient or converted the case and then performed a subtotal cholecystectomy, that single factor or the combination of an open surgery and a subtotal cholecystectomy was associated with a high 30-day mortality. Now, looking at these figures, one may wonder why the complication rate and the mortality is slightly higher. But this, I think, simply represents the typical pathology that is being studied here. And the severe nature of the pathology or the inflammation is partly responsible for these figures. It is often said whether a conversion in the face of a difficult callous triangle or a frozen callous triangle, or what Professor Strasberg in one of the classic lectures that he's given on culture of safety in cholecystectomy calls BIF, or biliary inflammatory fusion, where the Hartmann's pouch is completely fused with the biliary ducts. Whether a conversion is the way to save the day, whether a conversion is the right way to go forward. And it is probably not. This particular guidelines on World Society of Emergency Surgery guidelines on diagnosis and treatment of acute cholecystitis clearly state that they recommend a laparoscopic or an open subtotal cholecystectomy in situations in which the anatomic identification is difficult and in which the risk of iatrogenic injury is high. The quality of evidence for this recommendation is moderate, and the guidelines are the authors are fairly strong in recommending this particular solution. And they are not wrong. If you look at this paper from 2018, the title itself strikes home the message. The heavy price of conversion from laparoscopic to open operations in emergent cholecystectomies. So this was a analysis of a huge database of nearly 225,000 patients, out of which 4,200 or close to 2% had undergone conversion. And the analysis found that when conversion happened, the costs nearly went up by 259%, or about 2.5 times higher than the hospital cost in a non-converted cholecystectomy. There was a significantly higher mortality of close to 5% as compared to just 0.3% in the non-converted group. Again, a 0.34% mortality in a cholecystitis or a cholecystectomy may seem high, but please remember that this is a group which is often ill, has severe inflammatory changes in the right upper quadrant, probably even sepsis. So 0.34% mortality in this group is to be expected. But by converting the operation to an open, which often is suggested as a solution to this difficult scenario, may not be the right thing to do. So one thing is clear, that the conversion itself cannot be looked upon as a bailout procedure. What the surgeon is able to do, or what the surgeon is capable of doing after converting the operation to an open surgery, is the bailout procedure. So before converting, the surgeon has to always ask himself, am I going to be able to do something more or different that my skills do not allow me to do laparoscopically? And if the answer to that question is an unequivocal yes, then it is fair to convert and perform the operation which that surgeon could not have performed laparoscopically. But simply converting and then doing something that could have been done laparoscopically adds tremendously to the patient's mortality and morbidity. So in conclusion, ladies and gentlemen, Chairman, sir, to avoid a bile duct injury, a subtotal cholecystectomy, either laparoscopically or open, depending on the surgeon's level of experience and level of skill, should be strongly considered and performed when a critical view of safety cannot be obtained, particularly in the setting of severe acute cholecystitis. The decision to perform subtotal cholecystectomy or the reaching of the inflection point really depends on two things. It's the severity of the inflammation and experience of the surgeon. Keep in mind, though, that if you open the case and then perform a subtotal cholecystectomy, it may have a poorer outcome or carry a higher mortality. I hope that most of the those listening to this are convinced about the argument that I have made in favor of subtotal cholecystectomy being a good operation to be carried out in selective cases of severe acute cholecystitis. But for those who are not, I'm going to leave you with the words of a very wise man. Professor Barry Salke from New York has visited us in India quite often. And this was one of his slides that is imprinted on my mind. In that slide, he said, it is always better and safer to do a 95% cholecystectomy than risk a 105% cholecystectomy. So thank you very much, ladies and gentlemen, for your attention.
Thank you very much, Deepraj. We've heard your viewpoint on this. Now I'd ask Dr. Lakshmi Konakumari to present her views against the usefulness of subtotal cholecystectomy in severe calculous cholecystitis. Over to you, Dr. Konakumari.
Good evening, everyone. First, I thank Dr. Ramesh Agarwala, Dr. Sunil Popat, and Dr. Kanakvel for giving me this opportunity. It was a nice talk by Dr. Deepraj. I'll just... Yeah. So I would always prefer to do a complete cholecystectomy, because through Dr. Deepra's talk, we have seen that anything less than a complete cholecystectomy is always fought with lot of morbidity to the patient, and we are seeing also mortality apart from the disease. The surgical related mortality is also added to the sepsis, which has caused enough problems to the patient. So in our unit, we always do the gallbladders, whatever they are, complete cholecystectomy. And I would like to present my talk. So as we know that lap chole has become the gold standard treatment for gallstone disease, and it has over time, almost 2.5 decades, it has become the preferred way of doing the surgery because of less morbidity, short hospitalization, vis-a-vis the Cocker's incision, which we used to do when we were in our PG training. We used to do open gallbladders that time. That was associated a lot of pain, and the patient used to be in the hospital for at least 4 to 5 days. But here, the patient is just leaves the hospital just around 24 hours, and they're back to work within few days. So minimal access surgery has given the best advantage for the gallbladder surgery. But there are difficult times and difficult patients, and where the question of how to manage this happens. And we saw one view that we can do something partial and come out for the safety of the patient. Safety of the patient is always important, but then the patient is left with the disease, or the patient is suffering the consequences of being left with the part of the diseased gallbladder. And how can we help the patient to not have this morbidity associated because of the state of the disease? So complex cases where there's a lot of fibrosis, like Dr. Deepra said, maybe you have a small contracted gallbladder and you're not able to visualize where the gallbladder is, or there is severe inflammation and the critical view of safety is not easily visualized, or there is Mirzi syndrome, which already your radiologist has mentioned on the ultrasound report, or you're dealing with a patient where already subtotal cholecystectomy has been done, or you have made up your mind, the patient, I'll go in and do a subtotal cholecystectomy. Mainly if you're doing a patient where there is a chronic liver disease, there are a lot of surgeons are not comfortable taking the gallbladder out of the bed because of fear of the varices in the gallbladder bed. So they may think that we will do a subtotal cholecystectomy for this patient. So these are the things where your decision making and your surgical skills and your teamwork and all matter to the patient. So as we have seen with Dr. Deepra's talk, that wherever you have done or is advised to do a subtotal cholecystectomy, the patient has to understand that they may need a second look intervention, which could be a surgical intervention also, because we have seen subtotal cholecystectomy is present later with stump or remnant cholecystitis. Sometimes the stone, which is the cause of all this problem, is still retained within the cystic duct stump, and the patient is never cured of his symptoms for which all the surgical process was done. And it is not also easy to remove that cystic duct stone with endoscopic interventions. Now, these are the patients who will, again, once they're discharged from the hospital, will run pillar to post to get rid of the symptoms. And literature has shown, and as per Dr. Deepra's presentation also, subtotal cholecystectomy is a higher incidence of bile leaks from the gallbladder stump. Mainly more we see in the fenestrated variety, and this may need again ERCP. So if it done in remote places where there is no ERCP facility available, the patient has to be again shifted to another place in a sick condition for the ERCP to be done. And when you're opening the gallbladder, sometimes there are lots of stones and the surgeon is not able to handle all the spilled stones or the infected gallbladder contents. It may cause bacteriobilia and it may cause multiple intra-abdominal abscess, and which can add to the already sepsis which the patient is suffering. Sometimes when the posterior wall is left behind, maybe if there is it is acute on chronic cholecystitis, or you're doing the gallbladder surgery in a CLD patient, and you have not been able to burn the whole of the gallbladder mucosa, which has been left adherent to the posterior wall, then the patient may keep on presenting with recurrent abscess in the gallbladder fossa, and which may become more and more difficult to treat because the source of infection has not been cleared. So all this, apart from the medical burden, adds a lot of financial burden to the patient. And wherever the endoscopic intervention is not easily available, the patient would be shuttled and be running pillar to post to get that management done. It's not only endoscopic management, but it also needs intervention radiology. If there is a subphrenic abscess, or there is a purulent collection in the gallbladder fossa, or some of the collection has traveled and localized in the pelvis. Now, all these things sometimes may need intervention radiologists to put drains to get this collection out. So there are so many technical challenges which will happen if the primary surgeon is unable to properly do this surgery. So it needs more and more technical advancements to handle this thing. So I will just show the video. So I wanted to, there was a voiceover for this video. So you can see that this is what a typical difficult gallbladder would look, where there's lot of adhesions and you cannot see the Hartmann's clearly. So you have to first learn to do the adhesiolisis and then gently ease the duodenum from the Hartmann's, and then do a blunt dissection and expose the critical view of safety. So this, I will not say that someone with early experience can do this type of gallbladder, but yes, over time, with gradual improvement in the skill and also a little bit scientific courage, I would say. Like we talked of safe mountaineering, but if we only talk of safe mountaineering, I am sure Everest and all the mountain peaks would never be conquered. So the senior surgeons who have lot of better skills and good teams and would have got better instrumentation than the learning surgeons should gradually improve the skill set and learn to do these procedures, and also make it pertinent to train the younger surgeons rather than promoting partial cholecystectomy as a escape procedure. So once your critical view of safety is located, then usually most of the acute gallbladders can be peeled off the gallbladder bed unless there is severe CLD. And then if you're worried about the oozing, we have good hemostatic materials like the snow or the flow seal, which can be put into the gallbladder bed to control any ooze, and always the specimen has to be removed in an endo bag to prevent any port site infection. Now this comes to one more thing. So these are the particular scenarios which already Dr. Deepraj has described, where you have the gallbladder fundus is not at all visible, or the gallbladder is totally covered with adhesions, of which it could be the colon, it could be the duodenum. So these are what usually end up with a partial cholecystectomy, which is if it is done by the beginners. So here we have a gallbladder which is perforated at the fundus, but normally the plane should be developed at the Hartmann's, because if there is a perforation at the fundus, usually the Hartmann's is free. So you don't start doing the endocytosis from the fundus, but you go from bottom up. You create the plane at the Hartmann's, and then you go up. By doing that with your left hand, you're pushing back colon and the duodenum. So you're minimizing the chances of any injury to these two structures. And then once the adhesions are released, then you go close to the duodenum and then push the gallbladder up. And the Hartmann's would usually move up. So if there is any big stone in the gallbladder, then you can remove the stone, and that would make it easy to dissect in the callus. So you can either push up the stone, or you can make a small nick and get the stone out. So that will be easy to hold the Hartmann and then lift it up. Usually for this you need more than anything, you need a strong left hand, and usually very rarely you need advanced energy source like a harmonic which are using, but usually a blunt dissection with the suction apparatus is easy, because here the patient's liver enzymes were little elevated. So I plan to do a cholangiogram also. That's why I first cut the gallbladder off at the cystic duct, and then did the cholecystectomy, and then irrigated the area, and then whatever little serosal damage which I suspected, which has happened on the duodenum, I am placing few sutures so that there should not be any duodenal perforation presenting later. This is very important when you're doing any difficult gallbladders. And then I do a cholangiogram. I pass in a cholangiogram cannula, then see that there are no CPD stones, and then clip the cystic duct. So you should always have a cholangiogram facility available in the OT when you're doing these type of. So if you have any doubt, you can always do a cholangiogram to check whether your bile duct is safe or not, or sometimes if the liver enzymes are elevated, if there's any stones or sludge in the bile duct, because otherwise if you don't manage them, then the patient may present later with a cystic duct leak or a obstructive jaundice in the post-op period. And also we have the ICG facility. So in some of the centers where they have the ICG facility, they can use the ICG facility to see the course of the bile duct. And these are all the techniques which we have to take care, because these type of gallbladders, there's always a chance of injury to the common bile duct. So we should take all these precautions and keep all these things in our armamentarium if we are planning to do this type of procedures. Now you can see this is almost a perforated gallbladder, again perforated fundus. First make sure the contents are all sucked out, and then again close to the Hartmann's, slowly create the plane between the Hartmann's and the adhesions, and then you proceed up and then release all the omental and duodenal adhesions, and then again do the posterior dissection. You see most of the dissection I am doing using a suction cannula only. And then once you see the critical view of safety, then only clip the structures. Never clip the structures before you have the proper visualization of the critical view of safety. And then with blunt dissection, you remove the gallbladder from the gallbladder fossa. Sometimes you can see one axillary artery, or sometimes, rarely, you can find an axillary duct. So if there's any ductal structure or a thick structure visualized, better to clip it rather than taking it off with any energy source, because they can trouble you in the post-op period. Now, this is one more case. You see a case of recurrent cholecystitis where it's a contracted thick gallbladder. Now, keenly watch the dissection. So I am again going close to the lower part of the gallbladder, but the important thing you have to keep in mind is, in these type of gallbladders, the common bile duct can get pulled up. So as we are going around, I am not comfortable with the course of this structure, which for a youngster may think as a cystic duct and clip it, but it looks too wide for a cystic duct. So what I decided was that I will make a small nick in the Hartmann and first deliver off the stone. You can see there is a big stone there, which was not allowing me to handle the gallbladder. And then there's a small vessel there, so which we can delineate and clip. And then I cut off the gallbladder, and then what it looks is actually it's a mirizy. It's a mirizy with almost a effaced cystic duct, and this is the proximal part of the bile duct, and this is the distal part of the bile duct. So I do a cholecystocholidocoplasty. So only mirizy is one type 1 and type 2 mirizy, where you can use the gall to reconstitute bile duct. Otherwise, the reconstituted cholecystectomy for any other procedure usually has its own set of morbidity. If this patient develops any bile leak, then we can always do a ERCP. But mirizy happens very rarely. It is not a very common finding. So it happens rarely. So you should always keep your
Kuna, you are mute. Kuna, you become mute. Kuna, you muted yourself, or you're... Can you unmute yourself, Kuna Kumari?
In the meantime, you can invite Deepraj for rebuttal.
Yes. So Deepraj, are you there, Deepraj? So we've heard Kuna Kumari. Rebuttal
Yeah,
on the side, yes.
Yeah, so thank you, Lakshmi. It was an excellent talk, and just a couple of points I would like to make. So this seems to be a sort of debate between excellent skills of most difficult cholecystectomies versus the evidence in the literature. The points that I would like to make, first of all, is all that you said is fine, but that is to be considered in the hands of very experienced surgeons like yourself. So either we say that if there is a difficult acute cholecystitis, the younger surgeons, the surgeons who are learning, do not attempt it at all and refer all those patients to more experienced surgeons. That could be a valid viewpoint, that they can go ahead and do all the acrobatics and take the gallbladder out safely. But choosing between a bile duct injury, which we all know can have a crippling course in the long term for the patient, versus accepting a bile leak or a collection in the subphrenic space, subhepatic space, I think it's always, particularly for the younger surgeons, those who are learning, I think it's always safer to choose the latter. So just going to quickly just end this with one sort of slide here, and this is again a quotation that he who fights and runs away may live to fight another day, but he who is in battle slain can never rise and fight again. Unfortunately, the slaying in the battle here does not apply to the surgeon, but the slaying in the battle will apply to the patient. So that is the problem. If the patient sustains a bile duct injury and the complications of it, what he suffers may not really be comparable to bile leak or any of the other consequences. So I think the message should be loud and clear that in selected cases, depending on your experience, keep the option of subtotal cholecystectomy. Let that complication or let the completion cholecystectomy be done at the hands of another more experienced surgeon that you subsequently refer the patient to. Thank you.
Over to you, Kona. Your rebuttal. Kona, are you there?
I would not agree to the point saying that when will a younger surgeon learn to do a difficult case? If every time we say that you see a difficult gallbladder, do a partial cholecystectomy, and who is monitoring how much of the partial cholecystectomy that person is offering to the patient? Lot of times we see almost 2/3 of the gallbladder left behind. Now that is not partial cholecystectomy. So that is an incomplete cholecystectomy, and the patient is suffering. And the redo cholecystectomy is again fraught with the risk of bile duct injury. So you are saying that if you don't die in this battle, you are going to be killed in the next battle. So in this, when we are talking of so much of advanced surgery, where we are talking of people doing laparoscopic liver resections and we are doing laparoscopic ripples. That was the discussion in the last 2 weeks. When you are encouraging young surgeons to learn these type of procedures, why are we saying promoting subtotal cholecystectomy as an answer for doing this acute gallbladders, which is a very common disease? If the person will not learn to improve the skills or learn to work with a mentor to improve their surgical skills to do these difficult surgeries, how would you expect them to go anywhere beyond? So I think here, when we are talking of these difficult procedures, I would suggest that as we are talking on part of IAGES, encourage young surgeons to use mentors. Now we can have telementors. I think they are doing the this thing through Lab Guru and all. We can do the mentoring for them and guide them through that. And then beyond a point, let them have standard guidelines. It is not that they need to search across the country for a skilled surgeon. There are a lot of skilled surgeons, I'm sure, who are doing the gallbladders totally. And they should at least refer to those surgeons for the good of the patient. It is not that I have this patient and I have to offer whatever surgical skills I have. No, it is always in medicine we have been taught that you always refer the patient to a higher center if you feel that you are not able to tackle, rather than leaving the patient to their own fate, running around for an intervention radiologist, for an intervention endoscopist, and then searching for someone who is willing to do their completion cholecystectomy. So that is lot of pain to the patient for a common disease. This is not a rare disease that, okay, it will happen to few people. It is going to happen to lot of people. So we should tell the young surgeons, spend some of your time with centers where you will learn to do good skills, and don't use subtotal cholecystectomy as an escape route for each and every gallbladder. No, it is not. I will not support that. I will say that they have to learn. If they learn to do this, then only you expect this younger generation to do anything advanced in liver, pancreas, or anywhere.
So thank you very much. I think both of you all have put your viewpoints very well and very strongly. We all deal with cases of severe acute cholecystitis. And again, it depends on your experience, expertise, and how you can deal with it. when you are dealing with a severe case, you have two options. If you cannot find out the critical view of safety, the bailout procedures, either you abandon the procedure, refer to another center, or you have to do it according to expertise, one of the procedures being a subtotal cholecystectomy. But as Kona has rightly pointed out, that also has its own problems. It has a question of, again, a redo cholecystectomy. There may be stones, so they also have a problem. So definitely the way forward is to train our surgeons to take up more and more difficult cases, have good mentorship, and go for the complete cholecystectomy, which would give the complete cure to the patient. But having said that, but there will be situations where a person who's not very experienced, or he has to come out, he has to complete the procedure, and he may not have that facility of mentoring or telementoring at that particular time. So he has that option of either abandoning, or he has the option of subtotal cholecystectomy, where at least he has not subjected the patient to a bigger trauma of common bile duct injury and has completed the procedure. So basically, I agree with both of you all, but we have to see to it that the surgeons, as Kona said, the young surgeons shouldn't take this as an escape route, but they can utilize this procedure in some selected cases where it is necessary without causing more harm to the patient, which is very important. Being aware of the consequences which are there of a subtotal cholecystectomy, which needs to be done. And we should emphasize more and more on training. And subtotal cholecystectomy itself is not a very easy procedure, and it's quite difficult sometimes, and it's not very easy to do. So it again depends on the skill set, the experience of the surgeon, the facilities which they have in the hospital, and what backup team they have. So if they have a senior surgeon in the unit who's more experienced, then they can call for the help of that surgeon to try for the completion cholecystectomy. But if they are compromised, they can definitely choose, in selected cases, the subtotal cholecystectomy. So there is no, you cannot say that you cannot do subtotal or you should do subtotal. You have to choose your case as well. The only thing which we look forward is that we do no harm to the patient, and the patient is safe, and we don't add to the complications. So thank you very much, both the speakers. Mr. President, Kanavel, thank you very much for giving me this opportunity to moderate this debate. It has been a very learning experience, and I have enjoyed myself thoroughly. Thank you very much, and good night.
Thank you, Dr. Ramesh sir. Thank you, Lakshmi ma'am, and thank you, Deepraj sir. Can I now have the honor of inviting the president for his presidential remarks? Professor Sunil Papat.
Thank you, both the speakers, and thank you, Ramesh, for concluding it. Though this is such a debate that it cannot be concluded in 45 minutes, and we'll have another session on lap chole only for 3 to 4 hours where we can debate it further. But I think the take-home message should be, one should learn to do a proper laparoscopic cholecystectomy, and one should have proper training. But at the end of the day, laparoscopic total cholecystectomy is an important procedure, and the evidence suggests that in a severe cholecystitis patients, it is better to do laparoscopic subtotal cholecystectomy than damage the common bile duct. But one should aim for complete cholecystectomy. And with that note, when we selected these topics and speakers, we knew that there will be a lot of pros and cons and debates on the subtotal cholecystectomy. Now, the second topic is also very, very important: Achalasia Cardia and poem versus Ehlers cardiomyotomy. And all of us have listened to these debates on various platforms. Today, we are having two eminent speakers and eminent moderator from AIMS to give us their viewpoints and to come to some sort of understanding when to do what. So over to you, Kanagdar.
Thank you, Mr. President. Ladies and gentlemen, after an array of evidence-based debate on subtotal cholecystectomy, now we move on to the next important armamentarium of advanced laparoscopic surgery, the myotomy for achalasia. How it is done, OM or laparoscopy, is going to be the debate for the day. For that, I have the honor of inviting the moderator, none other than Professor Rajendra Prasad. He is a professor of surgery at the Department of Surgical Disciplines at the All India Institute of Medical Sciences, New Delhi. Professor Rajendra Prasad has been having a phenomenal academic background. He has 154 original publications. He has 2,150 plus citations. And he has been a UICC ICRET fellow. He has been a fellow to the University of Minnesota for bariatric procedures. And he is an American College of Surgeons fellow as well. Professor Rajendra Prasad has been instrumental in promoting the foregut surgery by and large. And he also has a special interest in advanced laparoscopic surgery of the entire body. Benign, malignant, congenital disorders, and whatnot in foregut and thoracic surgery has been the primary interest of Professor Rajendra Prasad. Professor Rajendra Prasad has been instrumental in creating workshops, live programs, and he has been instrumental for original research projects under the CTRI on various topics. On behalf of the President of the Executive Committee of the IAGES, may I have the honor of inviting Professor Rajendra Prasad, sir, to moderate this important session on achalasia of the cardia. Professor Rajendra Prasad, please. Please unmute yourself, sir. Sir, you are still in mute mode, sir. Yes, sir. Fine.
Now? Yeah, you can hear me now?
Yes, sir. Perfect, sir.
So thank you very much, sir, for those very, very kind words. I have been having special interest in achalasia, and we have been, dealing with it for last about 20-25 years now. And the debates over a period of time have shifted from Heller's myotomy versus balloon dilatation. Ever since the poem has come in, the debates have largely now shifted to Heller's myotomy versus a poem. And we have two very, very eminent speakers, Dr. Amol Bapai, who's basically a surgeon, but he has a lot of interest in endoscopic procedures, and he has done fellowships in gastroenterology, advanced therapeutic endoscopy, endoscopic ultrasound, and endoscopic surgery from France and Germany. Currently, he is heading the Department of Digestive Diseases and Endoscopy at Dinanath Mangeshkar Hospital and Research Center in Pune. The other speaker is also a very eminent and well-known laparoscopic surgeon with special interest in digestive diseases surgery, and he's the medical director of Zen Multi-Speciality Hospital in Chembur, Mumbai. And his hospital was recently awarded as Best Center for Advanced Laparoscopic Surgery in Maharashtra. So with these two very, very eminent speakers, I'm pretty sure that this debate is going to be very interesting. And without wasting any further of your time, I would like to hand it over to both the speakers to start their debate. I think first is Dr. Amol, you would be speaking first.
I guess so. Maybe Dr. Kanagwal can confirm that, but I think in the program, I think I go first and then Dr.
Yeah, so you can start.
Yeah, you are first.
During your presentation.
Okay.
And once you're done, then we'll move on to Dr. Roy.
Right. So, can you see my slides?
Yes, sir. Very well. We can very well see.
And I'm audible, right?
Yes, sir.
Okay. So, good evening, everyone, and thank you, IAGES, for this kind honor. And always a pleasure to have this debate on achalasia, and particularly when Dr. Roy is on the opposite side. I think we've done this how many times, I don't know. It's been quite frequent. So basically, we need to understand that achalasia, a motility disorder of the esophagus, which involves aperistalsis of the esophageal body, defective LES relaxation, and an impaired bolus transport and stasis of food. And we need to remember that there is no actual cure for the disease, and whatever therapy that we offer in these patients is basically palliative. This is because the only thing that we can do to these patients in the last 100 years of history of achalasia is relaxation of the lower esophageal sphincter, either by a myotomy or some drugs or balloon dilation, whatever, but we cannot bring back the esophageal body motility. This is something which is very important to note. And for this, myotomies have been described for more than 100 years, and the latest one is the peroral endoscopic myotomy, wherein we create a bleb in the mid-esophagus, a submucosal bleb. We create the mucosal incision, and then we create a tunnel by getting the scope into the submucosal plane. And we create a tunnel, and the tunnel goes right across the gastroesophageal junction for about 2 to 3 centimeters onto the gastric side. And once we've achieved this tunnel, which we can see on retroflexion over here, we perform either a circular, selective circular, or a full thickness myotomy, starting a couple of centimeters beyond the level of the mucosal incision and going across the gastroesophageal junction, completing the myotomy. Once the myotomy is completed, we confirm hemostasis, pull the scope back into the esophagus, and close the incision on the mucosa using a few endoscopic clips. So this is how it looks. So this is the barium, a timed barium before POEM and after POEM, which shows good drainage of contrast and good runoff into the stomach. So I'm going to address this debate on the basis of about 7 questions. So let us look at the safety and efficacy first of POEM, since it's a new procedure. So the outcomes of POEM, selected large studies which we reviewed about 1.5 years ago, and majority of these studies have close to 100 patients, some have even 500 patients or even 1,300 patients, and treatment success is in the range of 82% to 97% in majority of the patients, with quite low complication rates, and reflux rates are also manageable in most patients. The efficacy is to the tune of around 90% or more than that. And the effect of POEM is also sustained in the long term for about, this is a study where we published our data on a 2-year follow-up, and the conclusions were that POEM is safe, provides high technical success, and excellent long-term outcomes, because we can see that the clinical success was above 90% even at the end of 2 years. The second question is, how is POEM different from a laparoscopic Heller myotomy? So the advantage is that the procedure can be performed in an endoscopy room. It requires a standard gastroscope, transparent hood, and all these new equipment is required, which is probably not so common for the surgeon to know. But for an endoscopist, this is quite standard of care, and these are the things that are easily available in the endoscopy room. What is most important is we have a full control on the extent of the myotomy. We can either perform a full thickness or a selective circular myotomy, and the length of the myotomy can also be extended into the esophagus as per the desired length, especially in situations like spastic esophageal disorders, like type 3 achalasia or jackhammer esophagus, where it has been reported that, and it is known that one needs a really long myotomy, even up to 15 centimeters, and that can be offered by POEM without any complications. The other important difference is preservation of the phrenoesophageal membrane. In POEM, we do not mobilize the hiatus, we do not mobilize the vagus, because of which GERD symptoms are manageable in most patients, whereas in laparoscopic myotomy, Heller myotomy, the phrenoesophageal ligament needs to be divided, the hiatus needs to be mobilized along with the vagus, the vagus needs to be separated out, which can give rise to some neuropraxia and some gastric motility disorder in the immediate postoperative period. All these things can happen. The third question is, what are the comparative data between POEM and laparoscopic hilar myotomy in the last decade? So there are basically 8 studies, comparative studies. Majority of them have been retrospective earlier, as well as recently there are a few prospective studies available. All studies have shown an equal efficacy of POEM versus lap hilars and similar adverse events. And the differences have been in terms of operative time, pain and blood loss, and hospital stay and early resumption of work. And cost is also lower. This is particularly in the Western literature. In our scenario, I think the cost is very much similar, whether it's POEM or lap hilars in most major cities. Apart from that, there are 4 meta-analyses which have also been published comparing POEM and lap hilars, where they have shown that the efficacy and adverse events are similar and differences are in the terms of operative time in favor of POEM. So in both the comparative studies as well as in the meta-analysis, the efficacy and adverse events have been similar, but the smaller differences or minor differences have been in favor of POEM. Therefore, as a conclusion, this was the expert consensus statements which reported as a level of evidence of level 1 evidence and grade of recommendation B as for type 2 and type 1 achalasia, POEM and laparoscopic hilar myotomy have equal efficacy and safety. What about type 3 achalasia? So this was a multi-center comparative study and which showed that the results of POEM were far superior and significantly superior to that of laparoscopic hilar myotomy in this study, where only type 3 achalasia patients were selected, and the clinical response as well as the adverse events both were much lower in the POEM group. The fourth question is, what about patients with failed laparoscopic hilar myotomy? We all know that no procedure in achalasia has 100% efficacy, and all of us have our failures. And when a lap hilars fails, what do? The advantages of a POEM in this situation is that there is a direct visualization of the submucosal layer, because of which mucosal perforations are less likely to occur. And because POEM is submucosal and it does not alter the surrounding anatomy, planes are better preserved. We can go on the other side, on the posterior side, and because of that, further treatment or these treatment options can be safer. There's also a lesser chance of fusion of the myotomy line. This is hypothetical, nobody has studied it, but this is because we perform a significant lateral dissection inside the tunnel, and because of that the muscle gets retracted significantly laterally, because of which fusion is less likely to occur. So this was a study again which compared 181 patients with controls, 91 after a prior hilar myotomy and 90 controls, and these are all recurrences, and they showed that the safety profile and rate of clinical success was comparable in both the groups. I come to the next question, which is probably the most contentious issue, and I'm sure Roy is going to talk a lot about this, the issue of post-myotomy reflux. We all need to remember one thing, that in all patients of achalasia, pH studies is probably not the best indicator of reflux. This is because many decades ago, a couple of decades ago, this study proved that one needs to perform a manual examination of the pH studies, because most of the automated pH tracings give us an abnormal acid exposure time, which is most often because of fermentation rather than true reflux. And the issue is post laparoscopic hilar myotomy also, abnormal reflux stays, abnormal acid exposure time stays in up to 50% of patients. And that is because most of them still have some fermentation of food which is remaining stagnant in the dilated esophagus. Therefore, this is the graph which actually shows reflux as compared to this graph, which usually will show fermentation. Having said that, there have been reports in the last 2 or 3 years, based particularly on pH studies, that reflux after POEM has been very high, to the extent that there was this editorial which said that will reflux kill POEM. But now we need to put this in the right perspective. This is an original article of endoscopic versus surgical patients with idiopathic achalasia. And this was another comparative study which showed that this was a randomized study. And what it showed was reflux occurred, and it was quite high in the initial 3 months after POEM as compared to the lap-Heller myotomy. And reflux esophagitis at 2 years, it had dropped. But this was based on pH. When we look at symptomatic reflux, we can see that at 2 years, the symptomatic reflux goes down, and the acid exposure also comes to almost equal at the end of 2 years. So this is very important, that although in the initial phase, POEM patients may have some remodeling, and because of which reflux may occur, most of these patients can be treated very well with PPIs, and at about 2 years, the reflux incidence becomes equal, nearly equal for the POEM as well as the lap-Heller's group both. This is another graphical way of demonstrating this, that reflux rates are quite similar in both groups at the end of 2 years. What is again very important to note is that severe reflux, grade C or grade D esophagitis, is actually lower in the POEM group as compared to the lap-Heller group at 2 years in interval, although it was initially higher in the POEM group. So there have been measures now that even the POEM proponents have been taking to prevent or minimize post-POEM reflux. We need to understand that POEM has been a procedure in evolution. Heller myotomy is a procedure 100 years old. POEM is a 10-year-old procedure. And we need to remember that fundoplication was added after Heller myotomy nearly 50 years later, whereas there are methods to reduce reflux which have been implemented during a POEM procedure within 5 years of its inception. It is an evolving technique, and there have been a lot of debates about anterior versus posterior, selective circular versus full thickness, length of the myotomy on the esophageal or the gastric side, and the importance of the sling fibers. And also what is important is most POEM studies record results at around about 5 years ago, when many of these modifications had not been implemented, and all of them report reflux based on pH studies, whereas most laparoscopic Heller myotomy studies do not report pH results in the reflux groups, but they report only symptomatic reflux, which we all know is much lower as compared to the pH. And what is important to note is, even today in surgical literature, if we note, there is a contention regarding the efficacy of adding a fundoplication to a lap-Heller myotomy even after 100 years. Having said that, length of gastric myotomy, as in a surgical myotomy, is an independent factor which can contribute to reflux, and therefore we do ensure that the gastric length of myotomy does not go beyond 2 centimeters whenever we perform a POEM. Also, we try and preserve the sling fibers of the LES when we are performing a POEM, particularly in the posterior POEM, and that we perform by identifying the sling fibers during tunneling, and then we only divide the circular muscle fibers. With this, incidence of reflux is much lower. And there is also a procedure called as a POEM F, or a endoscopic fundoplication along with POEM, which have shown very impressive results. And this is obviously designed for not every patient who undergoing POEM, but at the same time, this can be offered to those patients who do develop reflux in later on after POEM, and the incidence of this is typically less than 1%. We reported our initial studies on this procedure, and out of 25 patients whom we performed this procedure on, reflux was seen in only about 11% patients, and 89% patients were reflux free. So that is the reason we can say that fundoplication also is now possible endoscopically. Now coming to the last question, is laparoscopic hilar myotomy ideal? Well, although it has been the gold standard for many years, safety and outcomes of laparoscopic reoperation for achalasia, the recurrence rates are around 20%, and the commonest cause is an incomplete myotomy. So the cause of recurrence of achalasia after a lap hilar myotomy is up to the 20%. It can occur because of an incomplete myotomy. So therefore, it may not be the best ideal procedure for achalasia, although it was the gold standard for many years. Again, around 5% complications with around 3% major complications, intraoperative mucosal injury 4%, which was not recorded as a complication, and readmissions and reoperations, and advanced age comorbid illnesses always increase the operative time or complications. So these are the other problems. And the reasons and prevalence of reoperations after laparoscopic hilar myotomy, 18% of reinterventions were either because of failure or because of complications, and 9% of repeat operations were because of an incomplete myotomy. So these are the recurrences after POEM in majority of the situations. In a redo laparoscopic hilar myotomy, we know that the complications because of scarring and fibrosis can be even higher, and conversion rates can be around 7%. Procedure times, efficacy, all are compromised in these procedures. The other question is adding fundoplication through the laparoscopic hilar myotomy and the role of the phrenoesophageal ligament. This is a very interesting surgical study which compared a hilar plus a DOR fundoplication along with a complete hiatal dissection, hilar DOR with a limited hiatal dissection, and hilar only with a limited hiatal dissection. And they identified that hilar DOR with a limited hiatal dissection and hilar only without a fundoplication, but hiatal dissection was limited, had comparable and low acid exposure and reflux rates as compared to whenever a hiatal dissection was performed, possibly because of division of the phrenoesophageal ligament. And therefore, limited hiatal dissection achieves a better post-op reflux control was the conclusion of the study, and POEM does not involve any hiatal dissection. Just as an evolution, and this is a point that I would like Roy to comment upon during his talk. This is a review article published in 1987 on surgical myotomy, and the authors in their concluding statement mention that additional anti-reflux procedures are only needed to compensate for an incorrectly done myotomy or are unnecessary. This is basically because only when the myotomy is incompletely performed, that is the time that incidence of reflux increases. And does fundoplication prevent reflux after laparoscopic hilar myotomy? So this is a meta-analysis of 21 studies of 601 patients. And based on the PS studies, they found that the comparison was 8% versus 10%. And based on the reflux symptoms, it was 6% versus 13%. Both of them not significant statistically. So therefore, reflux is not necessarily eliminated by addition of a partial fundoplication, and therefore no recommendations can be made about adding an anti-reflux procedure to the laparoscopic hilar myotomy. Therefore, to summarize on the basis of available data, laparoscopic hilar myotomy and POEM are equal in their efficacy whenever we are talking about type 1 and type 2 achalasia. Obviously, any myotomy is superior to pneumatic balloon dilation, although a graded pneumatic balloon dilation has results similar to laparoscopic hilar myotomy that has been shown. But while we are talking about POEM and laparoscopic hilar myotomy, their efficacy and safety wise, they are both equal when we are performing them for type 1 and type 2. For type 3 achalasia disorders, POEM scores over laparoscopic hilar myotomy because of the ease of being able to perform a much longer myotomy. And of course, POEM is superior for any other myotomy from pneumatic dilation. So, to conclude, POEM versus laparoscopic hilar myotomy, this is my argument. Let us remember that POEM is no longer a new procedure. We celebrated the 10th anniversary last year. This procedure possibly has the fastest acceptance for any new procedure in the history of medicine, with an excellent patient acceptance and high popularity. The possible reasons are it is less invasive, the results are comparable to laparoscopic hilar myotomy, length of stay is very short, adverse events are around 1%, and serious adverse events are very rare. Conversion to laparoscopy or open is almost unheard of. There is no scar and symptomatic reflux is comparable. Therefore, friends, it is time for surgeons to accept that POEM is here to stay. And my request to Dr. Popat, maybe the next debate should not be on POEM versus lap hilars, but should be regarding who should be doing the POEM, whether surgeon endoscopists or gastroenterologists with the surgical training. Thank you so much, and I look forward to listening to Dr. Roy Patankar on his side of the story.
Thank you, Dr. Amol, for that very stimulating talk. And I think now I'll hand it over to Dr. Roy for his view on what Dr. Amol has said. Dr. Roy, please.
Thank you, Dr. Prashad. Always a pleasure to be back in IAGES and debate with Amol once again. My apologies, because I was just told that this was a talk on achalasia. I did not realize that this was a debate, because the invitation also said invite you to speak on achalasia. So I think Amol has done the background work. I'm not going to show you the clinical details which I was planning to show initially. So I'm going to just skim through some of my slides, because these are technical things which I had put in because this was supposed to be a talk on achalasia. I'll cut these short and come straight on to the points debating. So Amol has made two rather controversial and mutually contradictory statements. He shows us some selective data from 2003 showing that addition of fundoplication doesn't prevent reflux. He then went on to show us some elegant slides about POEM F. So Amol, you need to make up your mind whether fundoplication done endoscopically or laparoscopically actually is required or not. As a surgeon's perspective, there is unquestionable data that not doing a fundoplication causes intractable reflux, many of which is volume reflux. In fact, if you look at all the articles, I've only quoted an article in 2004, but if you look at all the thoracic data, when people were doing open thoracotomy and hilars, 25% of people had intractable reflux, even despite lifestyle control and PPIs. So this is the very compelling data that hilars with a fundoplication is superior to hilars myotomy alone as far as incidence of post-operative GER. I am now amazed to hear his comments saying that symptomatic acid reflux versus pH data. All my life, I have always thought that a 24-hour pH is the gold standard, and suddenly we have the goalpost being moved by saying that 24-hour pH data is no longer important. Oh, you may get a lot of acid reflux, but it's not very symptomatic. So you should accept it and it's good. And the same endoscopists are now doing a POEM F, adding a fundoplication to. So I'm not really sure that, Amol always thought was a sensible guy, but he's as confused as the most therapeutic endoscopists I know in Mumbai. Look at this data. If you look at hilars myotomy versus hilars with DOR, unquestionable p-value data that you need to add an anti-reflux procedure. If you actually look at a paper from Annals of Surgery 2006, the majority of times so-called poor outcomes, this is a group which analyzed poor outcomes after hilars and felt that this is more a complication of GR and not incomplete myotomy. Which fundoplication? I'm not going to debate. It's actually, I was going to say that Tupe is marginally better, but no question that anti must be done. I'm again going to show you the same paper that Amol showed, which is a paper from surgical endoscopy looking at 10-year outcomes of lap hilars with DOR, which is a single center experience with the annual endoscopic surveillance. I'm reminded of the saying, there is your truth, there is my truth, and there is the universal truth. And the universal truth is what I'm going to try and show you in these papers. If you look at dysphagia after a lap Hellers and look at papers very carefully, it can be either an inadequate depth of myotomy, inadequate length of myotomy, could be linked to the fundoplication that you've done, or it could be linked to the body motility, which, as Amol says, never recovers. Let's look at each of these carefully. He first went on to say that in POEM, they do a much longer gastric myotomy, and I'll show you the ISD recommendations on this. And the second last slide, he actually mentioned that you should do only a small myotomy and preserve the sling fibers. Extremely important. Now, I have had experience of doing redo myotomies after POEMs for every endoscopist. I've done more than 26 redo myotomies in patients who previously had POEMs. And this data is available with me. It is not necessary, like he said, that POEM is not difficult after Hellers. I can tell you quite confidently, Amol, luckily most of you guys do posterior POEMs, and doing an anterior Hellers is not very difficult. What is difficult is doing a Hellers after Botox, and the only 3 mucosal perforations I've had in my life have all been after Botox injections. He mentioned about redo Hellers being a difficult operation, which is I agree. We initially were doing, and I must have a disclosure that in our center we do balloon dilatations, we do POEMs, as well as doing myotomies. So depending on what we feel is appropriate, we do this for the patient. And we've actually published our data in JLAST in the year 2017, looking at redo Hellers cardiomyotomy for recurrent achalasia. So lap surgery is feasible, though POEM, I agree, may be easier. Similarly, Amol, for a patient of POEM, a redo Hellers is much easier than doing a POEM again. We then come to some special situations like patients with, like this patient who had a large esophageal diverticulum. We see many such patients, and these are epiphrenic diverticula which come as a consequence of the achalasia. And what we need to do in these patients is to resect the diverticulum, which is something that you can't do endoscopically, so far at least. I'm sure Amol will think of a way of doing this also in the next year or two. But we have done more than a dozen esophageal diverticula. All of them are epiphrenic. They may range in size from 4 centimeters to 12 centimeters. Some of these patients have come to us with diverticulitis, occult blood positive. Some have even presented only with fungal pneumonias. So it's important, and all of these we were able to do trans-hiately. We have also published this in JMAS, and we had only a single leak in 12 cases. The key issue is to put an endoscope down the esophagus before you put your stapler across the diverticulum, and always oversew the staple line and then do a gastric serosal patch on this. Another unusual situation is patients with sigmoid esophagus. Now, it's our clear consensus that we will always do a myotomy first, informing the patient that even if he has a horizontal esophagus, they do get through 10 to 20 years before they eventually need an esophagectomy. And the second group of patients is those I'm showing you at the bottom video, is patients who are cirrhotics who come with achalasia. And I challenge you that most endoscopists wouldn't want to do a cirrhotic because of the periesophageal varices. We have now done 3 patients with proven cirrhosis who had accompanying achalasia. We obviously tackle the varices, try and bring the portal pressure down intraoperatively by using terlipressin. But this is a myotomy in a child acirrhotic who had significant aspiration and significant dysphagia in a cirrhotic. I completely agree with Amol's statement that the safety and efficacy of POEM is as good as Hellers. If you look at the Eckhart scores, POEM is as good as Hellers in all these things. Dr. Nageshwar Reddy also published his work in the Journal of Neurogastromotility looking at type 3 achalasia, and he said that type 3 achalasia's POEM is better. Now let's look at this contentious issue as Amol causes of post-op reflux. But remember, these are functional GI problems. It's not a cancer that the patient wants removed. He wants relief of dysphagia. He doesn't want morbidity. He doesn't want to take lifelong PPIs, and he doesn't want to wake up at night with liquid coming in the mouth because of reflux. He mentioned the difference between abnormal acid exposure versus GERD. Amol, you're really moving the goalpost by telling us that 24-hour pH data is no good. Well, I've been a fan of 24-hour pH data. I have a great interest in anti-reflux surgery, and to me, 24-hour pH data is as important as it comes. Another question looking at a paper in surgical endoscopy looking at comparative efficacy of first-line treatments for achalasia. We had a systemic review. Look at this very, very carefully. And even if you see Inouye's data, you see any data from across the world, there is 20 to 40% reflux after POEM. There is no two things about it. After years of denying reflux, suddenly our therapeutics endoscopists across the country have started doing POEM-F. I am unable to discern that change in thinking. Important to realize that there is a longer learning curve in POEM as compared to lap Hellers. You need far more endoscopic equipment and training. You need very good infrastructure. Not everybody is Amol Bape and not everybody is Niranath Hospital. Exactly like in the first debate, I felt like telling Lakshmi and Deepraj, a technique must be reproducible and replicable in the hands of a junior trainee working in periphery. You are able to do a lap Hellers in a small nursing home without fancy energy sources, only using a harmonic. The 2019 sole consensus on esophageal achalasia and the guidelines. So clearly there is no big difference as far as the safety and efficacy is concerned. Dysphagia relief measured by Eckhart score is comparable. This I am a little surprised when they said that the length of hospital stay is equivalent. In our center, POEM stay longer. Our lap Hellers go home within 24 hours. And the surgical time in a Hellers is much shorter than POEM, though this is not what this paper says, published from Martin's group. As per the 2018 International Society of Disease Esophagus guidelines, the best outcome of Hellers are for type 1 and type 2 achalasia. If you see the Las Vegas guidelines published in 2020, we now believe that for type 3 achalasia, you do a 7 centimeter esophageal myotomy and 3 centimeters on the stomach. So this is a direct contradiction to what Amol says by saying limit your gastric myotomy. I'm going to say do a good gastric myotomy because majority of failures, ladies and gentlemen, are because of inadequate gastric myotomies. Even routinely, you should be doing 6 centimeters on esophagus and 2 centimeters on the gastric side. Always come by a fundoplication. My own preference is the door, but you may also do a two-phase with this. Think about the availability of specific equipment, think of learning curve, the procedural challenges, the outcome differences, and mainly the 10-year outcomes. This is not a malignancy where we think of 5-year survival. This is a morbidity issue. This is a lifestyle issue, extremely important. Ladies and gentlemen, any patient coming to us wants these 4 things. He wants dysphagia to be relieved, which I agree, POEM is comparable to LHM. He does not want reflux and morbidity. And there is no question that POEM causes 20 to 40% reflux. You may call it abnormal acid exposure, you may call it GER, you may call it endoscopic, but a rose by any name smells as sweet. And the last thing is the cost and the time. I certainly don't know about Dinanath Hospital, but a lap Hellers in a general ward in our hospital costs 50,000 rupees and a POEM never costs below 95,000 rupees, needing the CO2 encephalator, the Irby knife, the multiple Olympus clips that my gastroenterologist uses. I rest my case, ladies and gentlemen.
Thank you, Dr. Roy. And 2 minutes, Dr. Mole, do you wish to say something to Dr. Roy? And then once more, Dr. Roy, and then we'll conclude it.
All right. So always interesting to listen to Roy's argument about, laparoscopic Heller and POEM. Now, Roy, as you mentioned, and I think you heard me wrong, maybe I'll send you my deck of slides so that you can review them later on. Few of the points that you said about the reflux part and also gastric myotomy part. Now remember that the principles of POEM, the surgical principles of POEM have not changed at all. We are following the same thing which surgical myotomy, laparoscopic myotomy, and POEM. 2 centimeters gastric myotomy is what has been recommended. And that is all that I said. So when you mention that we typically do a long myotomy, that is not true. In fact, it was one of the endoscopists in a POEM study who confirmed that in case a longer myotomy is done, incidence of reflux is higher. So please, we would like to, it's better to correct this point rather than go on with that. The other issue which you have been talking about, that reflux is more after poem, and you said that I was trying to change the goalposts. Now remember one thing, I am nobody to change goalposts, but the goalposts have been changed by global experts on reflux, mind you, not achalasia. Global experts on reflux who published the Lyon consensus 3 years ago about reflux and diagnosis of reflux. And if, with the permission of the chair, I would just like to share one slide to demonstrate this point. Now, this is what the Lyon consensus is, which is the current standard for reflux diagnosis. So conclusive evidence of pathological reflux is grade C or grade D esophagitis or acid exposure time more than 6%. And borderline or inconclusive evidence is grade A or grade B esophagitis and acid exposure 4 to 6%. And if it is lower than that, and even for borderline, one requires additional or supportive evidence. Without this, one cannot label this as reflux. So this is what is very important to remember. And the argument which I have put forth about the reflux point is a study performed during the surgical era of myotomy, performed by surgeons, that fermentation is a common factor, common reason why abnormal acid exposure gets labeled as reflux wrongly. So this is a paper from 1997 during laparoscopy times, early laparoscopy times and surgical times. So let us not confuse that by saying that we are changing, moving goalposts. The goalposts have already been changed. I do agree that diverticuli or other situations, special situations, can pose a much more difficult task when we are doing a poem. And yes, you can resect the diverticulum. Yes, and at the same time, that does increase the risk of a leak or a perforation. Diverticular myotomy is also reported, and that does give relief and empties out the diverticulum as well. So that can be done along with a poem. So we do have options for that. And of course, cirrhotics, we've done a few cirrhotics. I do agree that many of the endoscopists may not venture into doing a poem in cirrhotics. But then that is the reason I left my talk with the question to Dr. Sunil as to who should be doing the poems, surgeon endoscopists or others. So that is a question for some other debate at some other time. So this thought process, I do believe that yes, expertise-wise and skill-wise, we don't have Roy Patankars doing lab hellers everywhere, even in India or even in the world. You may say the same thing about poem as well. But then when we are looking at global standards and global general outcomes, that is the reason where you have presented very often, your arguments are based on single center studies. But the data which I have published and which I have presented is on consensus statements, very often, most of the time, national guidelines. So which are more broad-based studies which give the true picture in the community. And because of that, let us accept the fact that laparoscopic Heller myotomy is not without its problem. I do definitely agree that poem has probably not penetrated that long. It's only about a decade.
Can you conclude, sir?
Right.
Right, sir.
Right. So that is the only point which I would like to make. And regarding one point about the learning curve of Heller myotomy is more than 100 years. Poem, it is only 10 years, sir. So let us remember that as well. Over to you, Rai.
Thank you very much, sir. Dr. Rai, do you wish to say a quick?
Yes, sir. Amol also mentioned that it's perhaps less invasive because it's done in the endoscopy department. I think poem is far more invasive by any standard. You're entering the mediastinum, you have things like pneumomediastinum, pneumoperitoneum as consequences of this. And let me just end by a simple statement. If you ask me to choose a treatment for achalasia, if it is my mother, I would do a Heller's. If it is my mother-in-law, I would get a poem done. Thank you very much.
All right. Thank you very much. So just both speakers have given their viewpoints very nicely, and I would just like to conclude by saying very few words. One, that yes, poem is here to stay. I mean, it's not going to go away. Most societies would recommend that a patient is offered all the choices, and then a decision should be made in kind of consultation with the patient as to what that patient wishes. Most guidelines and societies also agree that poem has a higher reflux rate, and we must remember that one of the Achilles heels of Hallis myotomy has been reflux, and a lot of long-term studies have shown that reflux causes the long-term problems. So you can't just dismiss it away. Even in our studies, and most guidelines do accept and agree that poem does lead to a higher reflux rate. So that should be kept in mind and informed to the patients when we are talking about these things. Third is poem, as Dr. Mole also said, is still, I guess, in evolution. And maybe over the next few years, it will become more standardized. In our own institution here, we have seen people moving from long myotomies to shorter myotomies, and those kinds of studies are going on. And the very fact that people are trying to recreate a fundoplication, although that's actually not a very great way of doing a fundoplication. When you do fundoplication, it's not just flipping over the fundus. I mean, there is much more to doing a fundoplication than flipping it over and putting a stitch. But the very fact that the endoscopic people are trying to do that means that they do accept that there is a need for fundoplication. And by and large, the literature is very clear on this, that a surgical myotomy should be accompanied by a fundoplication. The other thing is that one of the things which I would like to share, which we have seen in our experience, and I think is reported in literature also, about 20-25% of the patients in whom you are trying to do a myotomy, achalasia patients will have an associated hiatus hernia, which is not picked up preoperatively. And these patients, if they are subjected to poem, I guess they would have a much higher reflux. The question of expertise and other things, they kind of apply, I guess, both to poem and myotomy. So I would like to end by saying that yes, both procedures are valid procedures. Both procedures give decent and equivalent results. There is also about type 3 achalasia, though initial there was a lot of enthusiasm that poem will perform better, but I think now we are getting studies which do say that probably with a properly done Hallis myotomy, you can achieve similar outcomes. So I would like to end it at this, that both are good procedures. Poem is still in evolution and will probably get refined over a period of time, and patients should be offered the choice of both. But we should keep certain caveats in mind as we have discussed. Thank you very much, and I would now like to hand it over back to the president of IAGES, Dr. Ko.
Thank you very much, both the speakers and Dr. Rajendra Prasad for summing it up nicely. And Amol, thank you for giving one more point and one more topic for debate next time: surgical endoscopists versus gastroenterologists. So all not tell even endoscopic community that you are revealing. But I think Dr. Rajendra Prasad summed it up very nicely. I had one question for Amol. When we do LHM, we, as Roy pointed out, we do 6 centimeter on esophagus and 2 centimeter on stomach myotomy. But when we do POEM, we do much longer myotomy on the esophagus side. Is it really necessary to do such a long myotomy on esophagus side?
Actually, the recommended myotomy is 6 to 8 centimeters on the esophageal side and 2 centimeters on the gastric side. It started with 8 centimeters, but most often people would do around 6 centimeters and 2 centimeters. That is what. So the tunnel is about 8 centimeters or even 10 centimeters, so that the mucosa, the mucosal incision and the myotomy are spaced apart adequately. The tunnel is longer, I do agree, but the myotomy is around 6 centimeters.
Okay. Second thing
Unless
is,
unless it is a type.
You showed it nicely how to save the sling fibers, but I think it's very difficult to save the sling fibers in the hands of all the endoscopists who are doing POEM.
No, it is actually anatomically proven now, and it is just that one needs to identify the perforating vessels. The muscle fibers are very clearly visible All our fellows can also do it now.
Very good. Very good. Roy, you mentioned that it's not that difficult to do LHM after a poem. Of course, if it is a posterior poem, then it would be very easy to do anterior LHM. But if it was an anterior poem in the past, what is the way out?
Sunil, some of the earlier redos we did in 2019 and 20 were from the Mumbai people. I have now done from Hyderabad, Pune, Mumbai, all of them. But initially, when they were doing anterior poems, what we were doing was we were looping the OG junction with a umbilical tape and rotating the esophagus and making our myotomy at 3 o'clock position. That was the way out of there. And surprisingly, there is less peri-esophagitis than you think there is. I think a redo lap Hellers after a failed Hellers is more difficult.
Very difficult.
Doing a Hellers after poem is not that difficult, actually.
Yeah. So thank you both very much. And with this remarks, we'll come to the conclusion of the event. I'll invite Kanakwal to take over.
Thank you, Mr. President. Thank you, Professor Rajendra, sir. Thank you, Roy, sir. And thank you, Amol, sir. It's been a feast of academics and data being debated. And I'm sure this will be an ongoing debate for a longer time. Thank you, one and all. And with the permission of the President, now I invite our dynamic Honorary Secretary, Dr. S. Ishmurthy, sir, to give his vote of thanks. Over to you, Dr. Ishmurthy.
Can you see my slide, Kanagavel?
Not yet.
We are able to see you, sir. Momentarily, we saw and it disappeared, sir.
Now?
Not yet.
Not yet, sir.
No.
Many thanks, Dr. Prasad. Sunil Bhai, appreciate your moderation today.
Thank you. Thank you.
We are able to see your PowerPoint, sir.
Thank you. Thank you. My dear President, friends, and ladies and gentlemen, I think today's prime time is a special one for all of us. It's a landmark event because I think tomorrow it's going to be a Doctor's Day with so many luminaries present here giving a stellar performance. I think we had a wonderful day. I think this is the first time in the history of IAGES we had two absorbing great debate of clinical relevance today. I think we need to thank our both the moderators, Dr. Ramesh Agarwala and Rajendra, having kept the time and also stimulating them, both the team, and give the fact-filled presentation. Very fascinating to listen to our Deepraj, Lakshmi, followed by Amul and Roy. It's always a pleasure and a treat to listen to them all with so much of evidence-based, all practical points. I think people across the country enjoyed this, and thank you again, Kanagavel and President, for bringing yet another nice show. And there are a couple of quick things from my office. As all of us know, the COVID is there, but hopefully it is fading away. But still, all our members and also the would-be members, please join. If not the on-site program, which will be started in probably from August end. Till then, we have our online FAGs, online EFAGs, and also the online false oncology open through our IAGES.in. Please log in, and please, we have all our people in FAGES board and also the endoscopy board are there, giving you all the interactive lecture modules and master videos so that we can all meet, hopefully on site in February 2022 in Rajamudri for a wonderful conference. And once again, I want to thank you all because IAGES, thanks to all of you, having given a liberal donation in the last 30 days, we were able to collect up to 30 lakhs. And the last one today, we were able to start our vaccination drive, starting from down south, thanks to our chairman, Zamir Basa and Dr. Govindraj. And I leave you all with this 3 minutes video to just to give a glimpse of what an IAGES and the social front can offer with all your liberal donation in the last a month or so. Thank you all. Have a safe night, Jane, and thank you, Docplexus, for another wonderful seamless transmission. Thank you, President. Thank you, Kanahavel, for a wonderful show. I thank all the people who have contributed here. I think we are all here working towards a path of excellence and also serve our people on a Doctor's Day tomorrow. Bye-bye now.
Thank you. Bye-bye.
Thank you, Yushka sir. Thank you, Docplexus team and people for watching us on Docplexus Facebook and YouTube channel. We look forward for an exciting next program. Soon will be announced by our president. Thank you and good night to all of you.
Bye-bye.